Hi, my name is Seth Baum. I'm a preventive cardiologist and clinical lipidologist, and today we'll be talking about familial hypercholesterolemia. And I've chosen to give this presentation because FH, or familial hypercholesterolemia, has become so incredibly topical today. It is important for us as clinicians to be fully familiar with all aspects of this very important disease. So here we go. So the objectives today will be to review lipids and lipoproteins, discuss FH as a genetic disorder, discuss the pathophysiology of FH. I'll go through some clinical presentations of FH, diagnosis and screening, current management options, and emerging therapies. So let's do a quick review of lipids and lipoproteins. Well, first of all, it's important to understand that LDL does not equal LDL-C or LDL cholesterol. So LDL is a particle that carries cholesterol and triglycerides around the body. It is important to particularize cholesterol and triglycerides and not to have these fats free floating, because otherwise we'd have problems. For example, when cholesterol is in an aqueous environment, it crystallizes, and we do not want sharp crystals floating around our bloodstream. So LDL-C, or LDL cholesterol, is the amount of cholesterol carried within the LDL particle population, whereas LDL-P is the number of particles that we have floating around in our blood. The particle structure is important to understand because it enables these particles to live in an aqueous environment. And basically what it is a spherical unit. So the outer surface of these particles has largely phospholipids, while inside the particles we carry the cholesterol and triglyceride. The other thing to understand about these particles is that they do have some protein on the outer surface, and there's a protein called ApoB100, which is an incredibly large protein that sits on the surface of all LDL particles, VLDL particles, IDL particles, and Lp(a) particles. And this very large protein structure weaves its way in and out of the surface of the lipoprotein particle. So all of the atherogenic lipoproteins will have this ApoB100 on its surface. We should look at FH, or familial hypercholesterolemia, as a genetic disorder. And the reason we need to do that is when we start viewing this as a genetic disorder, it falls in a different place in our understanding in medicine, and we treat it differently, and we evaluate the patient and the patient's family differently. So we should know that about 1 in 500 Americans will have the heterozygous form of FH, or the form where one gene is inherited from one parent and not one gene from each parent. Classic Mendelian genetics tells us that 1 in a million people will have the homozygous form of this disorder, but in fact that's actually being questioned at present, and many of us believe that many more people have homozygous FH than that 1 in a million. So it is a clinically recognizable genetic disorder. It's inheritable in an autosomal dominant fashion, and about 70% of the mutations have been identified in the LDL receptor gene. Interestingly, there are over 1,600 different genetic mutations that have already been described affecting the LDL receptor, which is really quite remarkable. Other genes, however, can be involved. The gene for ApoB100, that protein that lies on the surface of the LDL particle, can be affected. The gene for PCSK9 and LDL-RAP1 can also be affected, and you're going to see in a few minutes exactly what those do. So in severe hypercholesterolemic state, what happens? Well, our body's exposed to incredibly high levels of LDL cholesterol and LDL particles over a very, very long period of time. And this causes disease in our vessels. These people who have severe forms of FH can have manifestations of cardiovascular disease very, very early in life. I'm talking about when they're under 10 years old. And you're going to see some images of that a few slides down the road. Myocardial infarctions occur on average at the age of 42 in the heterozygote, and death at the age of 45. So The next slide shows us that FH can be caused by mutations in these 4 genes that we just described. Again, this is an image of the LDL receptor and how that can be affected by the genetic abnormality, the ApoB100, that big protein on the surface of the particle, the RAP1 gene, and also the PCSK9 enzyme that can be affected as well. The next slide shows us that FH is typically an autosomal dominant disorder, with the exception of the RAP1, which is a recessive disorder. Being a dominant disorder, autosomal dominant, that means that if one parent carries the genetic mutation and the other does not, there's a 50% chance that a child will have FH. This slide shows us that there are different populations called founder populations that actually have a very high incidence of the disorder. And the founder populations, such as South African Ashkenazi Jews, French Canadians, Christian Lebanese, can have a frequency of the disorder as high as 1 in 67 people. So that 1 in 500 can be a little misleading. And if you happen to have a number of patients from these backgrounds in your practice, you should pay very special attention to them, because they may in fact have the disorder. The next slide shows something that's certainly very important to me, since I live in South Florida, that we have a very high frequency of South African Ashkenazi Jews, French Canadians, and Christian Lebanese here, and this is kind of a hotbed for FH. Let's talk about the pathophysiology of familial hypercholesterolemia. The next slide shows LDL receptor metabolism, and you can see a series of different progressions in this slide. First, we have the binding of ApoB to the LDL receptor, which is in a coated pit. That's then internalized in a vesicle and goes into the cell. The LDL is then separated from the LDL receptor, and it's degraded, broken apart. Pieces of it are utilized, broken into cholesterol, fatty acids, amino acids, and then it's recycled. The LDL receptor is actually recycled and sent back to the surface of the cell on an as-needed basis. Now here we see what happens when the receptor fails to work. So either you can have a situation where the receptor is non-functional, you have too few receptors, or you have a problem with one of these other genetic abnormalities I described. What happens? We have all these LDL particles floating around in the bloodstream, and they're not being taken into the cell, they're not being degraded, they're not being metabolized, and you end up basically bathing in very high levels of LDL, and this causes vascular disease. And the next slide shows that. So the higher the levels of the LDL in the bloodstream, the more likely they will be to penetrate the vessel wall. And by penetrating the vessel wall, we develop vascular disease. So we can assess the atherosclerotic burden of a patient in FH by measuring all these different particles, the particles that are represented by VLDL, IDL, LDL, but really this is an LDL disease. So just knowing LDL cholesterol is really all we need to know in this particular disorder. So this next slide shows that as LDL accumulates, it will predispose us to developing cardiovascular disease. And there are 3 different lines here. And you see the line to the left, which shows that at very, very high levels of LDL, early on, you cross the threshold of developing vascular disease, and that's the HoFH patient, or homozygous FH patient. In the middle, we have the HeFH patient, who has somewhat lower LDL cholesterol, so develops vascular disease at a midpoint, whereas on the right, we have a line that represents a normal population. We should understand, though, that these thresholds, that crossing the threshold of developing vascular disease is not fixed in stone. We can do things that can help ourselves, or we can do things where we can hurt ourselves. So smoking will make you cross the threshold earlier. Having high blood pressure, being overweight, being sedentary, being diabetic, all these things make you cross that threshold of vascular disease early on, and therefore we need to control these things in our patients and help them not develop vascular disease. The next slide shows the biology of atherosclerosis and the fact that there are a number of contributing factors, and these include all the risk factors that you can think of, whether it's age, hypertension, diabetes, all those other risk factors. They all come together to create a worse picture if you have these problems. So now let's talk about the clinical presentation of familial hypercholesterolemia. And there are certain characteristics of HoFH, HeFH, and severe FH that we should understand. And the first thing is they have very, very high LDL cholesterols. And the cholesterols can be certainly over 200 and can go into the close to 1,000 range in some patients. When these people are treated, they can have various levels of LDL cholesterol. It could be actually as low as the 150s and as high as the 300 or 400s. There are cutaneous features that we need to know about, including the xanthomas and the corneal arcus, and we'll show some images of those a couple slides down the road. And we should also know that these people can develop symptomatic vascular disease as early as 5 years old. So the next slide shows a series of images that demonstrate xanthelasma, corneal arcus, Achilles tendon xanthomas, and other xanthomas as well. And I would just take a look at the slide to be aware of what these things look like. But I'll tell you from a clinical standpoint, what I do is when I examine a patient, I feel the pedal pulses, and then I move right to the back of their foot and feel their Achilles tendon and feel the thickness of the Achilles tendon. Because sometimes they don't have the big lumpy, bumpy tendon xanthomas, but just a thick Achilles tendon. So that's something we should do. I also use my iPhone, which is very handy, and I take a picture of the cornea, and it enables me to enlarge it and to demonstrate a corneal arcus where otherwise I might not have been able to see it. So that's a pretty handy thing to be able to do as well. The next slide shows some images of very extreme and very severe cases of HoFH, where the patient has developed aortic stenosis that's severe, and also a very severely calcified aorta. And you see some CT images on this slide. The clinical course of the patient with HoFH is really very bad. They develop severe vascular disease at a very early age. There are numerous case reports of bypass surgery before the age of 10. Severe aortic stenosis can occur, as I just showed you in the slide before, and untreated, these people usually die by the age of 30. Almost all HoFH patients require LDL apheresis, even when they have maximal medical therapy. And now there are new drugs available that have been FDA approved for HoFH, and we'll talk about that at the end of the presentation. In the heterozygous FH patient, or the HeFH patient, these people are at very high risk too, so we shouldn't ignore them. They have a 20-fold increased risk of cardiovascular disease, which is pretty substantial. If untreated, men have a 50% incidence of cardiovascular disease by the age of 50. That's 50% by the age of 50. Women, 30% by the age of 60. So it's a very, very significant risk. In terms of diagnosis and screening, there are different ways to do this, and I'll discuss the most common ways that we have available. There is still really some debate as to how best to make the diagnosis of HoFH and also HeFH. So first, we have a clinical approach, and then there's also a genetic approach. And here in the States, we typically don't use the genetic approach, we use a clinical approach. And the clinical approach includes obviously a lipid assessment, and we could just do a standard lipid profile on these patients. We don't need to do advanced lipid testing, although advanced lipid testing can be helpful and interesting. And then there are three major criteria that we can use: the Simon-Broom Register, MedPed, and the Dutch Lipid Clinic Network. So let's briefly discuss each of these. In Simon-Broom, we have different categories, A through E, and depending upon where the patient stands with regard to meeting these criteria, he or she will or will not be diagnosed as having HeFH. MedPed is Make Early Diagnosis, Prevent Early Death. That's what that stands for, MedPed. And that has its own set of criteria. As you can see on the MedPed slide, and this is very important, LDL cholesterol will change with gender and age. So women tend to have a lower LDL cholesterol than men until menopause, at which point things start getting worse for the women, unfortunately. And young people have a lower LDL cholesterol than older people. So that means when we're making the diagnosis, we have to take age and gender into consideration. Next, we have the Dutch Lipid Clinic Network diagnostic criteria for FH, and it's a point system, and you have to have greater than 8 points in order to meet the criteria for definite FH. As far as genetic testing goes, in the United States, FH is, as I said before, usually made on clinical grounds. Genetic testing is, however, obviously the gold standard of diagnosis. But we have to remember we can miss about 20 or 30% of patients when we try to make the diagnosis on a genetic basis. So therefore, again, in the States, we typically don't do that. Next slide shows some diagnostic methods, advantages and disadvantages, and it compares clinical and genetic approaches. And you should just know that a clinical approach obviously is far less expensive than a genetic approach. That's one major thing we should look at. And it has the limitation that I just discussed, which is that there is a variation of LDL based upon age and gender, and we have to consider that when we're making a clinical diagnosis. The downside of genetics is we can miss a lot of people. Next slide demonstrates a patient with HoFH. And this is pretty disturbing when you look at this image, because this is a 28-year-old woman. She has cutaneous xanthomas that had started at the age of 3, and she has obstructive coronary disease, and if you look at the image on the right, she has left main disease, and she had a bypass at the age of 12. Her LDL cholesterol was 780. The next is an interesting patient, a 38-year-old woman who's a healthcare practitioner who I met at one of the talks I gave. And interestingly, she was in the audience. And when I started talking about this disorder, she mentioned that she had a very high LDL cholesterol. And this is basically who she is. She's adopted, so we have no family history. She does, however, have a history of high cholesterol. She was never diagnosed with a genetic disorder. She has 2 children. Their lipids are unknown. At the age of 32, these are her labs. Total cholesterol 388, LDL cholesterol 318, HDL cholesterol 45, triglyceride 124, LDL particle number 2977, and LP(a) 8. So based upon these numbers, you can certainly say that she most likely does have FH. So what I did was I took out my iPhone and took a picture of her cornea, and this next image is her cornea, and you see a corneal arcus. And when you have a corneal arcus and you're under 45 years old, it's pretty much pathognomonic for FH. She also has significant Achilles tendon xanthomas, and she was unaware of these. So I felt her Achilles tendons, and in fact they are not only thick, but there certainly were the lumps and bumps consistent with the Achilles tendon xanthomas. This is an image of that, not a great image, but this is her Achilles tendon, and you can see a little discoloration, and that's where the Achilles with the xanthomas are pushing against the skin. The next image is that of carotid intima media, and you see a plaque, and there's an arrow there showing the plaque. Next image, the same thing, a little plaque, a very small plaque in the carotid artery. This is a very good way to assess your patients to see whether or not they have subclinical disease. This woman did have definite heterozygous FH. She has a corneal arcus, she has tendon xanthomas, she has premature vascular disease in that her carotids demonstrated some plaque, and she had a very high LDL cholesterol. What's the treatment? It's aggressive. She needs aggressive lipid-lowering therapy, and she also needs aggressive therapeutic lifestyle changes. She was not exercising every day, and she was overweight, and so these are things that we need to deal with. It's not just a medication issue, it's a lifestyle issue as well. She also needed intensive cascade, or not intensive, she needed cascade screening. She has 2 children. Nobody has looked to see whether these 2 children have the disease. We need to know early on whether they have the disease, because don't forget, It's the duration of time you spend bathing in this very high LDL that puts you at risk for vascular disease. We want to save her children before they develop the progressive vascular disease. The next slide shows the Simon Broom register, and you could plug her into this and you'll see she definitely has met criteria for heterozygous FH. Next is MedPed, met it there. And finally is the Dutch Lipid Clinic, and if you plug her into that, she's very well met that as well. The next is a 36-year-old gentleman who has a family history of premature atherosclerotic heart disease. Now his total cholesterol is 272, LDL 200, triglyceride 130, HDL 46. He was physically fit, not obese, active. One thing you can notice from this is, and you can notice it from her labs as well, FH patients tend to have high normal triglycerides. They're normal, but they're high normal. They also tend to have low normal HDLs, and both he and she had these phenomena. They also tend to have a greater frequency of elevated Lp(a), so it's always important to check that in your FH patients. The next image shows his coronary CT angiogram, and he does have coronary disease, even at his young age of 36. So the consequence of making this diagnosis, and don't forget we discussed the issue that this is a genetic disorder, so we made a diagnosis of a genetic disorder in him. So what did he do? He accepted our standard therapy. Instead of saying, oh no, I don't want to take that statin, it's going to make me feel sick, it's going to do bad things to me, look, he's read on the internet all the horrible stuff that statins can do. He accepted the therapy. He sees he has the disease. He sees he has a genetic disease. Perhaps even more important than this, he allowed us to assess his 9-year-old daughter. And interestingly, his 9-year-old daughter has a total cholesterol of 230 and an LDL of 131. And if you look at her age and gender, she's over the 95th percentile for age and gender. So her LDL cholesterol of 131 actually puts her in the category of FH. She likely has the HeFH as well. So this is cholesterol screening recommendations from the National Lipid Association. And it's important to recognize what we're saying here because it really goes against what most physicians think we're supposed to do. So we should screen patients at the age of 2 if they have a family history of FH. That's 2 years old. All other children should be screened between 9 and 11. And we do treat these children, even with statins, at very young ages if they have FH. Next is cascade testing to identify FH patients. And if you have a patient with a clinical diagnosis of FH, you can go one of two ways. You can go the genetic route or you can go the clinical route. If you've made the genetic diagnosis, then you can cascade screen with genetics. If you haven't, if you've done it clinically, then you can cascade screening, as I've discussed before, using the 3 different sets of criteria that we've already discussed. So diagnosing FH is easy. It leads to obviously better management of patients, results in the recognition and treatment of affected family members, and we should understand that only about 20% of FH patients have currently been diagnosed, leaving about 80% of people undiagnosed. If we don't recognize the disorder, we can't treat the disorder, and these people are walking around undiagnosed, suboptimally treated, and will have a much higher incidence of significant cardiovascular events, and that's why it's so important to keep FH very much in the forefront of your mind. So current treatment. So what do we do about this disorder? Well, the foundation for everything is therapeutic lifestyle changes, and it is for this as well. So diet is very important. Reduce saturated fats, reduce simple sugars, refer to a dietitian if you have a good dietitian who you have a good relationship with or who you know is particularly knowledgeable in this field, refer to a dietitian. Exercise. These patients, and we all should exercise on a daily basis. Statins are the mainstay of therapy. And the interesting thing is, you might be saying, well, wait a second, statins work on the basis of upregulating LDL receptors, having us produce more LDL receptors. If these are defective, how are statins going to work? Well, it's true that that's how statins work, but it's also true that statins will reduce LDL even in the homozygous FH patient. So this is not a black or white issue. There are many shades of gray here. We should know that standard risk stratification tools, such as Framingham risk scoring, is really inappropriate in the FH patient. They are already at the highest risk. So there's no need to do a Framingham risk score on these people. Goals of therapy. Pretty much we want to lower their LDL by at least 50%. The ultimate goal, of course, is with an LDL cholesterol under 100. Many of us would like to get the LDL cholesterol under 70. It's important to know that proper therapy, good management of LDL, and management of the other risk factors that I've already discussed can lower the risk of coronary heart disease by up to 80%. So we can make a significant impact on this disorder. Next slide is current therapeutic options for FH, and it starts with the statins, and we've already discussed that. We start with reducing cholesterol synthesis and then upregulating LDL receptors. Now, LDL receptor upregulation really is the common denominator in all of our lipid-lowering therapy that we use in FH patients, including the bile acid sequestrants and including the cholesterol absorption inhibitors. The next slide shows effects of statins and lipid-lowering therapy in FH, and the reason this slide is so powerful is that it demonstrates that you can, with statins, even in the HoFH patient, you can improve their outcomes. You can reduce their risk of mortality and, of course, morbidity. The next slide is an image of an LDL apheresis center. This is actually my center in Boca Raton, and these can be comfortable places where people can undergo LDL apheresis, which is basically hooking them up to a machine for about 2 hours, pulling out the LDL, and they can watch TV during this procedure. They're very comfortable. It's something that you should definitely consider for your FH patients because it's very effective. And there's some European literature that has shown a 72% reduction in risk by using LDL apheresis in the FH patient. Next slide shows how this works, and you basically, after each treatment, you lower their LDL cholesterol very, very significantly, then it goes back up, then you lower it again. You're doing this every 2 weeks in the HeFH patient, can be every week in the HoFH patient, and then you hit a new baseline that's lower than your initial LDL baseline. What you're really looking at is a time averaged LDL. So you want to lower your average LDL that you have over time. Because again, the lower the LDL, the less cholesterol the patient is bathing in, the vessels are bathing in, the less likely the patient will be to have a cardiovascular or a cerebrovascular event. Next, we move on to novel therapies. These are new therapies. And lomidopide was the first approved, and it's an MTP inhibitor, and I'll describe that in a second. It's a small molecule, so it's delivered orally, and it was FDA approved in December 2012. Mipomersen is the other drug that was approved. It was approved early in 2013. Uses antisense technology. Again, I'll describe this a little more. It blocks the translation of ApoB100 mRNA into ApoB100 protein. It is a subcutaneous injection and it was, as I said before, approved in January of 2013. So this next slide takes us through MTP, which is microsomal triglyceride transfer protein, and the inhibition of that. And we see that MTP is critical for the assembly and release of ApoB-containing lipoproteins. And we see how this works. So we have a liver cell, and we have an intestinal epithelial cell. And this is occurring at the endoplasmic reticulum, specifically the rough endoplasmic reticulum, which is the one that has ribosomes on it, and that's what makes it rough. And that's where we build proteins. And here you're building a protein which is ApoB100 in the liver cell, ApoB48 in the intestinal epithelial cell, and you're creating that big protein that will then have inside it triglycerides and cholesterol. And in the liver cell, you'll make VLDL, and in the intestinal epithelial cell, you'll make chylomicrons. MTP is the transporter that is transporting these fats to the protein, i.e. ApoB, to build the particle. And we need transporters for all fats, because when fats go in aqueous solutions, again, they don't like being in an aqueous solution, and they need to be transported or carried, and they're carried by these proteins. And in this case, it's MTP, microsomal triglyceride transfer protein. The next slide shows the synthesis of VLDL and chylomicrons, and you could just follow it along. You have the ribosome on there, you're building the ApoB, you're wrapping it around the triglycerides and the cholesterol, you're producing the VLDL, you're producing the chylomicron, and you could see how that works. Now what happens if we inhibit it? And you could see over the next couple of slides that the inhibition of MTP by lamidopide does a couple of things. It blocks the production of VLDL, which downstream will lower LDL quite significantly. It blocks the production of chylomicrons. And as a potential side effect to this, we have to be aware that some of the fat can back up in the liver and some of the fat can back up in the intestine. So we have to pay attention to that. Mipomersen works differently. And mipomersen's an antisense drug. So what happens here is you have an ApoB messenger RNA, and you have mipomersen. And mipomersen comes along and binds that messenger RNA for ApoB, and by so doing prevents the translation of that messenger RNA into the protein of ApoB. If you don't have the protein, you're not going to be able to wrap those particles and create those particles. And specifically, you're blocking ApoB100, so it's only going to affect the VLDL and subsequently the LDL production. It will not have an impact on chylomicrons. Next slide shows a few remaining options, and really pretty much nobody's doing these things anymore. They're invasive procedures. Each one has its downside. They include portacaval shunts, liver transplant, and ileal bypass. Again, people who just are not doing this anymore. In terms of the emerging therapies, the PCSK9 neutralizing antibodies are pretty topical, and we anticipate release of these drugs within the next couple of years. So what does PCSK9 do? It regulates LDL metabolism by degrading LDL receptors. So if you have a lot of this PCSK9 around, you'll degrade your receptors. If you degrade your receptors, you're not going to have them available to pick up the LDL particles, and your LDL levels in the bloodstream are going to be high. So these are, the PCSK9 inhibitors are antibodies to PCSK9, blocking the effect of PCSK9 and thereby blocking their destruction of LDL receptors and allowing LDL receptors to be more prevalent and allowing LDL therefore to fall. And here's just a slide demonstrating one of the trials. And next we have the thyroid hormone analogs. Here's one of them. You can read the slide, really no need to take up your time right now. And then the next slide is just management of the FH patient in the adult patient. So, or management of FH, excuse me, in the adult patient. So we have, as I said, the foundation, always, I don't care what we're treating in cardiovascular medicine and frankly in all other medicine, it's lifestyle modifications. We should all be maintaining optimal weight. We should all be eating healthful diets. We should all be exercising every day. Then there's drug therapy, and the FH patients typically require combination drugs. Statin is the mainstay of therapy. Then we add on other drugs. And then we have the two new agents that have been approved for HoFH. And then LDL apheresis, of course, is always a consideration when LDL apheresis is available. It's a very effective management strategy. So in conclusion, FH is a common and potentially lethal genetic disorder, and I emphasize genetic. We have to emphasize that with patients because it's very, very motivating for them. It's underdiagnosed, and as a consequence of being underdiagnosed, it's undertreated. It is actually easily diagnosed on clinical grounds. We just have to be aware of it. We have to be aware of the physical exam manifestations. We have to be aware of the LDL levels that would make us think, this person, I think, has a problem, has FH. Once we identify the patient with FH, we then have to do cascade screening. We have to look at first degree, second degree, third degree relatives to be sure that these other relatives don't have disease. You really have to look at everybody. We have to eliminate other cardiovascular disease risk factors, and we have to understand what our treatment options are, and they include the newer agents in addition to our standard therapy, and they include LDL apheresis. So as a final plea, I would say please help spread the word. Talk to your colleagues about this. Talk to your hospitals, your patients, and just be on the lookout for FH. it is a potentially life-threatening disease that we can't effectively treat now. Thank you very much.